I'm I work as a data scientist at the University of Nottingham within a group there called the Digital Research Service. And for the past, say, 2 years, so I've been part of the recorder team at the University of Nottingham as well, and led by Fiona, focused on rare disease research. So it's great to be here today to talk about the MELODY study. That represents a significant effort in leveraging national disease data for mass recruitment in rare disease research, and it's with a focus on understanding COVID-19 vaccination effectiveness. Obviously, with all things, this is a reflection of the efforts of a large collaboration. We're working with National Disease Registration Service, NHS England, NHS Blood and Transplant, and several institutions like Imperial College, University of Southampton, and the University of Nottingham. So hopefully I'll go through what we had set out to achieve with MELODY and the roles of mass recruitment and disease registries, some of our first publication findings, and also where we're headed. What is the MELODY study? So the MELODY study is an acronym, obviously, for Mass Evaluation of Lateral Flow Immunoassays to Detect SARS-2 Antibody Responses in Immunocompromised Patients. So a bit of a mouthful, but in essence, it's an initiative to assess the immune response to COVID vaccination among immunosuppressed patients. Specifically, the at-risk groups of those who have received either solid organ transplant, they have a rare autoimmune disorder, or they have hematological malignancy. So the background to this work, sort of going into it, was that the preliminary outputs of the REACT and OCTAVE studies was that we knew that immunocompromised individuals have shown weaker immune response to COVID vaccination, and also so this sort of gap in protection was a significant concern, especially given the heightened risk of severe disease and potential viral shedding in these populations. So what were the core objectives? We've got firstly, it was to determine the proportion of immunosuppressed individuals who develop antibodies following a primary vaccine course, which includes 3 doses. And this helps us understand the level of immunity these vulnerable groups achieve through vaccination. And secondly, second part of that objective is to understand how the various factors, demographics, disease specific, and also the key point, the treatment that they might be being given, affect the antibody response in these individuals. And the second part of the MELODY study was to sort of build on that first and examine the relationship between the prevalence of antibodies and the risk of subsequent infection and the severity of their infection. The outcomes of interest we're sort of looking at here was using, for COVID infection, the SGSS, second generation surveillance system. For hospital COVID-related admissions, we were using the HES database, and for deaths, we were looking at ONS mortality. So to give you an idea of the timelines, we started recruitment in December 2021. It was open for 6 months, and then there was a 6-month follow-up period from that. So it stands as kind of the largest kind of bit of research into the vaccine effectiveness in these often overlooked populations, and it's sort of leveraging real-world data and building on prior research. So the importance of national disease registration. So how did we actually go about mass recruiting in these cohorts? We've got 3 at-risk cohorts. So we used in the national disease registries, and these enabled sort of firstly precise identification of the study participants. This helped us sort of surmount quite a common obstacle in rare disease research, which is difficulty recruiting a large and dispersed participant base. So within with the use of these registries, we were able to recruit sort of on a scale large enough to yield sort of statistically significant insights. And quite critically, they offered a centralized, sort of standardized, secure source of data that enabled comprehensive data linkage. So by connecting health data across these like various different data sets, looking at our outcomes in our 6-month follow-up, we can effectively follow up the participants and assess the severity of subsequent infection. So additionally, there's a key point is that registries operate with strict sort of ethical legal framework, and also this allowed us, the study, to sort of operate in a sort of data and sample collection directly from people's homes, so it minimized intrusion and maximized convenience. So this slide sort of overviews that process. It was slightly different between the two, the rare disease group and the transplant group, and the cancers group. But what was the recruitment strategy? So for cancer and autoimmune disease, we sort of randomly invited participants from the NCARDS and the NCRAS registries via letter. So it was a broad sort of targeted reach to this vulnerable population. And for transplants, we initially allowed self-registration, but then also employed sort of targeted invitation afterwards to hit our goal of about 12,000 participants per cohort. And then, so once they'd gone through this, they were asked to do an antibody test at home, and that was a lateral flow immunoassay, and then to complete a questionnaire, online questionnaire, and then key in our analysis, we then linked it to a sort of existing registries. So the mass recruitment sort of achievements, I guess, to quickly show, we had an initial target around 100,000 individuals, and we successfully recruited around 28,000. So that's roughly sort of 9,000 from the solid organ, and then so around 28% of 28,000, so 28% of that initial target. This sort of represents quite a positive outcome. So by using these patient registries and doing targeted invitation, we were able to have quite a high engagement rate, and it shows the sort of trust and willingness of the community to contribute to research on COVID vaccination. And also the consent rates were relatively high of further data linkage. So around only 100 of the recruited ones were opted out due to consent. So then, just to overview again the sort of whole Melody process, this first part was initial phase was to quantify antibody status. And so we had some descriptive statistics to summarize the demographics of this group, and using the lateral flow immunoassays, we could determine whether they were positive or negative. And then we could then model the relationship between the antibody status and the participants, and the characteristics the participants showed in that population. And we could sort of see what aspects of the conditions or demographics were predictors of successful immune response. So these were then published, so we published them in the Lancet Rheumatology, and sort of the key messages here from this initial phase was that about 20% of the participants had detectable levels of antibodies, and we observed a significant trend, so the proportion of individuals with antibodies decreased with additional booster doses, so strongly supports the importance of booster vaccination. And also we could look at, say, the effect of certain treatments on our populations on the likelihood of being antibody positive. So this can sort of drive sort of clinical messaging on potential risk stratification and at-risk groups. And I guess a key conclusion as well is that we can identify and we can contact immunosuppressed people, and we can perform this assessment at scale using lateral flow immunoassay. So to very quickly, because it's Health Data Conference, just to make two notes on the difficulty working with the survey data. So it was quite a vast bit of data, and I think one key step was this idea of validation at ingestion. So we worked with the metadata from the sort of people who are rolling out the survey to ensure that when we received the data, we could immediately start this feedback loop of where the data quality issues were, and we could look at sort of expected distributions of things, and take that forward. And also, of course, just to note that we did this whole thing with reproducibility in mind. So trying to hit these sort of key components of a RAP pipeline within the constraints of working in sort of a bit of a constrained environment. So this is my last slide, Fiona. So just to quickly wrap up so the two parts of the study. So they've got a second part that's ongoing. The research is currently going. It's this 6-month follow-up, which is all this sort of data linkage with our hospital episode statistics, the admissions, looking at the deaths, and also just infections with SGSS data. So that's where we're at the moment. We can't share it just yet, but the preliminary result looks really, really interesting. So hopefully we'll be able to sort of guide help the clinical messaging and sort of even policy with these kind of results. So I'll end there. Thank you.